morning, everyone, and thank you for being with us on a Saturday morning. We'll start our program talking about the treatment of osteoporosis. There are multiple international guidelines talking about the matter of treatment of osteoporosis. These guidelines have set their criteria of treatment based on the profile of the patient of being either a woman or a man. The women group have been further divided into premenopausals and postmenopausals. The man group have been divided into being younger than 50 and older than 50. Most of these international guidelines, usually, they combine the premenopausals with the men younger than 50 and the women postmenopausals with men older than 50 in one guideline. In Kuwait, we have a local guideline about the treatment of osteoporosis. This guideline was established in 2008 by Osteoporosis Fighting Committee in the Ministry of Health. The committee included 3 endocrinologists, 1 rheumatologist, 1 gynecologist, 1 general practitioner, and 1 orthopedic surgeon. Our guideline was not away from the international guidelines, but it took into consideration the profile of the local population, the availability of the drugs, and the ease of access to different investigations. The guidelines were recently updated in 2014. We have introduced some of the newly administered drugs, and we have omitted some of the drugs that were not showing good efficacy. And hopefully, at the end of this year, 2015, we are going to have the latest version. We're going to have the latest version of our guidelines. And we are also going to have a separate guideline for the treatment of steroid-induced osteoporosis. The Kuwaiti guidelines of 2014 is divided into 2 parts. The first part is the part of the treatment, and the second part is the part of the screening. The first part is the screening, and the second part is the treatment. Now, whom to screen? You have major risk factors, and you have minor risk factors. The major risk factors are being older than 60, history of fragility fracture after the age of 40, history of parental hip fracture, systemic steroids more than 3 months, malabsorption conditions, primary hyperparathyroidism, hypogonadism, early menopause before the age of 45, osteopenia apparent on X-ray, and if you want to do a follow-up after at least 18 months. For the minor risk factors, you have 3 categories. The first one is the medical condition, the second one is the modifiable conditions, and the third one are the drugs. The medical conditions are diabetes, hyperthyroidism, Cushing, growth hormone deficiencies, anorexia, RA, COPD, chronic liver disease, chronic renal disease, osteogenesis imperfecta, major depression, MS, hematological malignancies, hemophilia, and thalassemia. The modifiable conditions are smoking more than 20, weight less than 57, caffeine more than 3 cups, vitamin D deficiency, calcium intake less than 600 milligrams per day, and recurrent falls. The drugs are steroids, proton pump inhibitors, cytotoxic drugs, anti-epileptics, SSRI, gonadotrophin-releasing hormones agonist, immune suppressants, heparin, lithium, excess vitamin A, aromatase inhibitors, and thyroxine in supraphysiological doses. Now, if your patient is above 50, then you're going to need 1 major risk factors and 2 minor risk factors. If your patient is younger than 50, then you're going to need, again, 1 major risk factor and 2 minor, excluding the modifiable conditions. We have excluded the modifiable conditions from this guideline in the young population because of the increasing reports of vitamin D deficiency and high prevalence of smoking in the local population of Kuwait. So if you take the modifiable condition, then you're gonna screen more of the young people inappropriately for osteoporosis. when you consider your patient for the screening of for osteoporosis, you're gonna do the DEXA scan. At the same time, also, you're gonna check for blood tests or other investigations looking for secondary causes of osteoporosis, like CBC, LFT, bone profile, parathyroid hormone, thyroid, according to the condition that you are facing with your patient. Now, according to the results that you are gonna get from your DEXA scan, your patient is gonna be either normal or osteopenic, which is a T-score. I'm talking about the T-score because these guidelines are set only for the postmenopausal ladies. So you're gonna use your T-score and not the Z-score for evaluating such patients. So the osteopenia is a T-score, which is between -1 to -2.4. The osteoporotic patient T-score less than -2.5. And the severe osteoporosis, which is a T-score minus than 2.5 plus a fracture, or less than -3.5. If your patient's DEXA scan is normal, all you're gonna need is just an annual examination of the patient's height and weight, back pain, kyphosis, and you may repeat your DEXA scan within 3 to 5 years. If your patient is osteoporotic or severely osteoporotic, you're gonna proceed for the treatment. Now, the dilemma is when your patient is osteopenic, which is a borderline, you will get a T-score between -1 and -2.4. Such patient, you're gonna categorize him for high risk of fracture to decide upon his need for the treatment. Now, you have 2 ways to do so, to categorize your patient. The first one is to use the FRAX tool. The FRAX tool is a tool which is available online, or you can download it through the App Store on your smartphone. The FRAX tool is gonna give you the 10-year fracture probability for the risk of fracture for the patient. If the patient's having a hip fracture of more than 3%, or a major osteoporotic risk fracture of more than 20%, then you would consider him for the treatment. If you don't have the FRAX tool or you don't like to use it, then you can categorize your patient for being a high risk, having more than one risk factor of being older than 75, history of previous low trauma fracture, RA, IBD, gastrointestinal bypass, organ transplant, family history of hip fracture, current smoking, or low BMI. Now, we are going to talk about the second part of the guidelines, which is the treatment. As I said, if you have an osteopenic patient with a high risk for fracture, or osteoporotic, or severely osteoporotic, you would proceed for the treatment. You can add to this group patient with a history of a fragility fracture after the age of 40, defined as a single vertebral or hip fracture or more than one fragility fracture. These patients, you would treat them regardless of the result of your DEXA scan. The treatment of osteoporosis is 2 parts, non-pharmacological and the pharmacological part. The non-pharmacological part is just modification of the lifestyle of the patient. You would discontinue or limit smoking, alcohol, or excess caffeine, weight-bearing exercise around 30 minutes per day, measures to reduce the risk of falls, and you can use hip protectors in individuals with high risk of falling. The pharmacological part would start always of correcting the vitamin D and calcium supplements of the patients, treat the vitamin D deficiency if present, and maintain your patient in 1,000 international units per day or equivalent dose to keep your vitamin D between 75 and 150 nanomole per liter, and maintain the patient on a calcium of 1,200 milligram per day, preferably always through diet, if not through supplements. The pharmacological part, or the anti-resorptive treatment for the patients, it has been divided into 3 lines, the first line, the second line, and the third line, based on the efficacy of the drugs and the proven reports of the fracture risk reduction. If, as I said, the patient of the osteopenic osteoporosis and the history of fragility fracture, the first line of the treatment is, the first line are the alendronate, denosumab, or the zoledronic acid. All of them have proven efficacy in reducing the risk of fracture in the vertebral, non-vertebral, and the hip fracture. The second-line drugs are of less efficacy, and they have proven fracture risk reduction in the vertebral part only, and they are the abendronate and the raloxifene. The third line, the strontium renalate or the Protilus, this drug has been recently, in the 2015 guidelines, have been omitted from this guideline. It is banned from the Ministry of Health, and due to the recent reports of increased incidence of myocardial infarction in postmenopausal ladies who have been treated with the Protilus. After 5 years of patient being on bisphosphonate, always consider a holiday period. If your patient is low fracture risk, which means they didn't encounter any incidence of fracture while being on the drugs, or their BMD is not deteriorating, then you could consider a 1 to 2 year drug holiday. If your patient is still of a high risk for fracture, then you may continue your drug for 8 years. Reassess the risk, and if your patient is still of a high risk, then consider changing your drug to another class. These were for the patient for the fragility fracture, osteopenia, and the osteoporosis. It's a little bit different for the severe osteoporosis, which is a T-score which is T-score minus than 2.5 plus a fragility fracture, or T-score of minus 3.5. These patients would need teriparatide or the Forteo, which is a daily subcutaneous injection. The maximum period you can give this drug is from 18 to 24 months, and it is only given once in a lifetime. And you should always follow the Forteo after you finish your period with bisphosphonate. The Forteo has shown proven efficacy in reducing the fracture risk in vertebral, non-vertebral, and the hip. The contraindication to use the parathyroid hormone is hypercalcemia, hyperparathyroidism, skeletal malignancy, Paget disease, and radiation therapy. If you have any of these contraindications, then give your patient bisphosphonate or something else. To monitor your treatment for the patient, repeat your DEXA scan every 2 years, preferably on the same machine and with the same operator. To monitor the progress of your patient and to monitor the efficacy of the drug, always compare your bone mineral density and not the T-score. The T-score is only used for the diagnosis of the patient, but to monitor the efficacy of the drug, compare the older with the newer bone mineral density. The treatment assessment, you would consider your treatment as a failure if there is a decline in the BMD, or if your patient had an incidence of more than one fracture while being on the drug. At that point, you should rule out non-adherence and secondary causes, including medication. And you would consider your treatment as a success, even if your BMD is not improving. A stable BMD or improving BMD, this is a success of the drug. This schedule combines all the available anti-resorptive treatments in the Ministry of Health. As you see, you have the lines. You have the first column talks about being a first line, second line, or third line, the name of the medication, the evidence of fracture risk reduction, and the renal dosing, the modification for the renal dosing. All of the anti-resorptive drugs cannot be used in severe renal failure, except for the denosumab. Just one last point. Please always consider correcting your vitamin D before you start a patient on anti-resorptive treatment. Don't use 1-alpha tablet as a correction of vitamin D deficiency or as a maintenance dose of vitamin D for your patient unless your patient is a chronic renal failure or his hypoparathyroidism. And I take this opportunity to invite you all to join us on our celebration of the World Osteoporosis Day, which is going to be on the 20th of October in Salwa Sabah Hall in Marina Mall. Thank you.